dilatational tracheostomy. Well, we're here today to do a percutaneous dilatational tracheostomy. This is a patient who is ventilator dependent, has not been able to wean off of the ventilator, and the tracheostomy should help speed that process up and help us get her into rehabilitation sooner. We have just completed our timeout to ensure that we're operating on the right patient, we have the right procedure. She has been sedated and has been paralyzed. She's on controlled mechanical ventilation. We have her pre-oxygenated with 100% oxygen, and we've ensured that we've got her adequately sedated and comfortable to begin. What we're going to do is do what we call a modified percutaneous tracheostomy. Traditionally, the way this procedure was originally described, you would actually stick through the skin and directly into the trachea. The risk with that procedure, though, is having a paratracheal insertion. And so most people have switched to what's called a modified percutaneous tracheostomy, where we'll actually make a small incision of about 2 centimeters in the anterior neck, directly over the trachea. We'll dissect down to the trachea so we can feel the tracheal rings, and then we will insert a needle into the trachea under direct palpation so that we know exactly where we are and we know that we're directly in the trachea. So what we're going to do first is go ahead and infiltrate the skin with some local anesthetic that has epinephrine in it to help reduce the risk of bleeding. We can either make a transverse incision or we can make a midline incision. Either is probably fine. There may be a little bit less bleeding with a midline incision, and so that's what we'll go ahead and do. So basically I'm feeling for the cricoid, I'm feeling for the sternal notch, and we're estimating where the second tracheal ring will be. It's about midway between those 2 points. We're just going to make about a 2 centimeter incision. And if we stay in the midline, the bleeding is really very minimal. Communication among all the members of the team is very important at this point to make sure that the patient remains comfortable. We need to watch her vital signs and make sure that if she needs additional sedation that we can go ahead and give that to her. What I'm doing is just slowly going down through the subcutaneous tissues, staying right in the midline, feeling with my finger exactly where the trachea is. And I'm beginning to feel the tracheal rings now. The secret is not to get off on one side or the other, because that's where we can get into some bleeding. So I can feel the trachea now, I can feel her tracheal rings. What we're going to do now is begin to back the endotracheal tube out while I'm pushing on the trachea. And as we slowly begin to back that out, all of a sudden I'm going to feel the trachea soften as the endotracheal tube is pulled back. Communication with the respiratory therapist at this point as to exactly where the tube is very important.
We're at the 20, Dr. Tatum.
Okay. Let's come back just a little bit more, please. What we're doing here is we're rocking the tube back and forth a little bit, which makes it a little bit easier to feel it through the tracheal wall. A little bit more. Keep coming back just a little bit. Okay, just a little bit more. Okay, I can feel the tip of the tube. Just another ½ centimeter. Okay, good. All right, what we're going to do now is take a catheter over a needle that has a little bit of lidocaine in it, and we will stick into the trachea and look for air bubbles that will come back into the syringe, telling us that we're inside the trachea. There are those air bubbles. So I know that I'm in the trachea. Now what I'm going to do is I'm going to advance the catheter off and down into the trachea. And what we'll do is we'll pass a wire down through that catheter. And it's really helpful if the assistant can hold on to the wire so it's not flopping around. Okay, we'll take the catheter out.
Give her more.
Yeah, how about another 50 of fentanyl, please? Okay, so this is a punch that's going to go ahead and make the hole in the trachea a little bit larger. Okay. And now this is the dilator that we'll pass over, and that will slowly dilate up the trachea. We've already prepared our tracheostomy tube. We normally would put an 8 tracheostomy tube in a male and a 6 in a female. So we have a 6 Shiley tracheostomy tube ready to go. You can hear the air coming out of the trachea, which tells us that we're in. How's your blood pressure? Okay. Okay, and now it's just a smooth motion, putting the tracheostomy tube in. And now we'll bring the ventilator tubing over the top and hook up to our tracheostomy tube. We'll inflate the tracheostomy cuff. And we're looking for return of end tidal CO2, which we have. We're also looking at tidal volume.
Positive tidal volume.
Okay, we have that. So the tracheostomy tube is now in place. And now we'll go ahead and secure it with suture. Many times we're able to get patients off of the ventilator within 24 hours. Once the tracheostomy has been placed, we frequently will put them on a tracheostomy collar that afternoon, and they usually tolerate that very well. And so there you have a percutaneous insertion of a tracheostomy tube.